Good afternoon. My topic is on long-term outcome of treatment with diode laser therapy for retinopathy of prematurity. ROP is the cause for visual impairment in premature infants. It's been documented that about 20,000 premature survivors worldwide have visual impairment and blindness. Prematurity, low birth weight, and ROP increase the risk for myopia. There's a rising trend for refractive errors, strabismus, and amblyopia in these children. Hence, we designed a study because there are only countable studies in literature published from India about the long-term outcome despite ROP treatment with diode laser, which has started last 20 years. So we aim to analyze the long-term refractive ocular biometric profile, sensory outcome among the children with minimum 6-year follow-up. Ours is a retrospective cross-sectional interventional follow-up study done among children 6 to 15 years of age for a duration of 6 months. We included children who came to our OPD with a past history of diode laser therapy for ROP with a minimum of 6-year follow-up. We excluded those who spontaneously regressed and those who required surgical intervention. So from the case sheet, we collected data about gestational age, birth weight, neonatal risk factors, extent of ROP, laser therapy, and the retinoscopy, which was done at 1 year of age. So at presentation, the child underwent a visual acuity, color vision, contrast sensitivity, slit lamp biomicroscopy, prism cover test, binocular single vision, stereopsis, dilated biometry, cycloplegic retinoscopy, and indirect ophthalmoscopy. Coming on to my results, we had 41 children, 80 eyes. The mean age at evaluation was 9.77 years, the mean gestational age being 30 weeks and mean birth weight being 1430 grams. This table is on the severity of ROP and treatment details. We had 3 eyes with structural sequelae. This table is on refractive outcomes. Our mean visual acuity among a study group was 0.175 logmar, 2032 Snellens, and 89% had visual acuity better than 2040. Mean contrast sensitivity being 1.64 log units, mean color vision 96%. Sensory outcome, the pie chart shows 31% had exotropia and 63% had orthotropia. These are our refractive outcomes. We had 91% incidence of refractive errors, mean spherical equivalence minus 5.29, myopic refraction in 88%, astigmatism in 66%, anisometropia in 36.58%, mean spherical equivalence at 1 year of age being minus 2.28, myopic shift 2.99, mean myopic shift per year 0.34 diopter per year. When we compared our patient details, refractive components, and our biometric outcomes with 7 other studies in the literature, we found that our patient characteristics were very similar to the other studies, whereas our mean spherical equivalence and myopia were also corroborative with the other studies being a little high. The mean axial length and the lens thickness, the mean axial length is slightly higher than the mentioned studies, and mean lens thickness is slightly lower than the mentioned literature. This table is on comparison of gestational age, birth weight, zones, and presence of AP-ROP with the refractive and the biometric components. We found that visual acuity was significant among the birth weight groups, proving higher the birth weight, better the visual acuity, whereas spherical equivalence and myopic shift were significant among the birth weight and gestational age group, proving lower birth weight and lesser gestational age group children had higher spherical equivalence and myopic shift. This table compares the low and high spherical equivalent groups with the refractive and the biometric components, where the visual acuity, myopic shift, and the axial length were statistically significant among the spherical equivalent groups, showing that high spherical equivalent eyes proved to have increased myopic shift and increased axial length, which was similar to Kaur et al. Study. So myopia is multifactorial, and the etiology of myopia is controversial. There is an increased lens thickness and an increased axial length among these children. Various study reports, Nguyen et al. He correlated myopia to be more among the ROP laser treated eyes in comparison to the non-ROP and spontaneously regressed ROP, and our study group also showed myopia to be very significant among this treated children. ETROPs suggest increased myopia to be more in more severe ROP children rather than its any direct effect to the laser therapy, which was not suitable in our study. Yang et al. Hypothesized there is an incomplete postnatal development in these premature children. Choi et al. He documented the axial length among the low and high myopia groups, and the axial lengths were very similar to the axial length documented in our study too. So, the present study showed an increased axial length with a significant myopic shift. Most studies reported in the literature shows an increased lens thickness to be a contributory factor for myopia. Our study revealed that myopia was influenced more because of an increased axial length. Coming on to my conclusions. So our study showed a good refractive outcome, a favorable structural outcome. We had significant number of children with high myopia, astigmatism and strabismus. We found that myopia is multifactorial. Axial length could be a major contributor, and also child's birth weight and gestational age has a bearing effect on the outcomes. Our study being retrospective in nature and lack of control group are our limitations. We suggest that our threshold to prescribe glasses in these ROP children should be low. There requires an awareness among practitioners about the hidden future challenges, mainly about the refractive error and amblyopia. We suggest that there should be a strict neonatal care, early treatment, so as to control the severity of disease and reduce myopia. So a timely and meticulous long-term follow-up is required in these children. These are my references. Thank you so much.